Hello, everyone. My name is Brad Chickwin. I'm a paramedic as well as a hospice nurse. Today's program is going to be over a topic called Empathizing with Death. If you have the opportunity, I would highly suggest you attending this program when I teach it live, as it has numerous interactive videos, which, due to the platform limitations of this program, I cannot show these videos. A little bit about me. I have a couple college's degrees, associate's degree in paramedicine, bachelor's in health sciences. I also have an associate's degree in bachelor's in nursing. I'm a board certified critical care flight paramedic. I've held a host of EMS roles throughout my career. I'm a 20 plus year firefighter paramedic by trade. And I also work as a hospice nurse for Andwell Hospice of Southern Maine. That's my own disclosure. The disclosure is that I am a hospice nurse, so some of the slides and the information provided in the slides come directly from Andwell Hospice of Southern Maine and what we use out in the field. Course agenda, we're going to discuss the difference between empathy and sympathy, the stages of dying and mourning. We're going to cover hospice and palliative care, death with dignity, the difference between a pulse versus a DNR, initiation of orchestration, so this is how we're going to deal with a loss of a patient in the field. Grieving memory aid kind of helps us formulate how we're going to discuss with the family the death and dying process after their loved one has died. Briefly cover organ donation and then discuss what we can do to improve our mental health. So around the death and dying process, how much training did you receive in any schooling, whether it's EMT school, paramedic school, and nursing? Most of us, this is what we got in school when we were in EMT or in paramedic school. The 5 stages of grief and loss. As you see in this diagram, it's circular. It includes acceptance, denial and shock, anger, bargaining, and depression. It is definitely circular. It does not go in a straight line, and some people never get out of the circle. Why don't we train on this? Ignorance is bliss. In EMS, there's not a whole lot of educational opportunities around the death and dying process. Because of this, many providers are not comfortable pronouncing somebody in the field, or after they do pronounce them, having the conversation with the family to break the news. If you look at our protocols, ironically, we have 14 of them that deal with death and dying, yet we don't have a whole lot of training to fill the gap about this process. That's what I'm hoping to provide to you today. So let's start with a couple terms. Empathy versus sympathy. Many folks don't realize there is a difference. We, as healthcare providers, really need to strive to learn how to be empathetic. Empathy fuels connection, where sympathy drives disconnection. Empathy recognizes emotion and tries to relate. Empathy feels with people, where sympathy is seen as pity, which patients don't want from us. So let's take this one step at a time. Kubler-Ross defines stages of dying as the perspective of the patient is a series of 5 emotional responses where an individual faces their own terminal illness or significant loss. They start off with shock and denial, then they become angry. Depression and detachment sets in. Dialogue and bargaining ensues. Then they accept their terminal illness, and then they return to what is their new norm and live a meaningful remainder of their life. As you see, it's not circular, it's not linear, but it's a series of loops and bends to get there. Teresa Rando's stages of mourning comes from the family's perspective. So it's the journey, which is an active, systematic process of working through grief to adapt to life after a significant loss. Unlike Kubler-Ross's model, the 6 R's of mourning emphasizes the experience of the loss and the psychological tasks they need to move through in order to start to heal. So after somebody dies, the initial response is avoidance. Then they recognize the loss, and then they attempt to confront it. There's a reaction that occurs. They recollect the experience. Then they start to relinquish old attachments. Then the accommodation starts. They readjust to what the new world is without their family member. And then they reinvest their energy in their emotional responses to moving forward. Factors that influence loss or grief. This is how a family member responds to death, and it depends on a variety of reasons. The ones I'd like to draw your attention to are coping strategies and culture. Some people, as we know, deal really well with loss, whether they have experience from it or they have coping mechanisms to help work them through it. As it pertains to culture, there are some cultures to which embrace the death and dying process because in their culture, the afterlife is the ultimate goal. Again, we need to be respectful on different cultures and how they deal with the death and dying process because it's going to be different most of the time than yours. So let's start to discuss hospice and palliative care. Palliative care versus hospice care. Palliative care focuses on prevention, relief, and reduction of symptoms. The goal is to help achieve the best possible quality of life. Part of the prevention while on palliative care, patients will still do cancer treatments, have blood transfusions, and be part of medication trials. When they fall into hospice care, they focus on the prioritized care of themselves according to their wishes. The goal is to manage their pain, provide comfort, and ensure quality of life. When you become a hospice care patient, you are deemed to have less than 6 months to live. At this point, these patients are no longer doing cancer treatments, blood transfusions, or participating in medication trials. They're only taking the medications to help manage their pain and provide good comfort. Part of the implementation process of the death and dying process when we deal with our patients is therapeutic communication. Through therapeutic communication, we establish caring and trusting relationships by using open-ended questions. We provide the psychological care as well as manage symptoms to promote dignity and self-esteem and maintain a comfortable and peaceful environment. This is where the power of touch is very important, to be able to humanize the experience for these patients and their family members. Pop quiz. When you are on hospice or palliative care, are you required to have a signed DNR? The answer is no. It's not very common, but they do not have to have a DNR. Why? Medicare certified programs allow patients to retain full code status. Typically, there may be a delay of obtaining a signed DNR due to personal, cultural, or religious beliefs, or because they have not yet already accepted the fact that they no longer want full resuscitation efforts to occur. So let's talk about hospice care and our protocols. Main EMS has designed a protocol to help guide us as providers in the field if we interact with a patient on hospice care. It is our job to provide and support patients and families during this time. We owe it to them and to the patient to help them get their symptoms relieved and become comfortable and not transport them to the hospital. When a patient's on hospice, typically the hospice service that they're under are responsible for the payment of an EMS transport, so discussions should occur with hospice personnel or nursing prior to transporting. It is important because some patients that are on hospice have enrolled in the hospice system because they don't want to die at the hospital. So we need to do everything we can to keep them at home. Usually we get activated via 911 to something unrelated to the hospice patient's terminal illness. If we're going to a patient who's on hospice, we should avoid a variety of things. Licensed sirens, IV therapy, CPR, BVM ventilations, pacing, cardioversion, defibrillations. It is in our fabric to save everyone we encounter, but remember these patients don't want that. It's not up to us to decide, it was up to them. Many of these folks can and should be treated with an alpha level response. When a patient's on hospice care and we respond to them, if you don't feel comfortable, you always have the opportunity to call online medical control. But 100% of the time, the first thing they're going to ask you is, did you reach out to the hospice company directly? All of these hospice patients have a comfort kit in their possession to which is designed to treat their symptoms. This is a huge practice change for us, right? We're so used to going into a patient's home, seeing what their issue is, fixing their issues acutely, and transporting them to definitive care. In these cases, it's completely different. Once we confirm the patient's on hospice, we need to slow down, limit the amount of folks in the room, and be respectful. Many of these hospice comfort kits are being utilized by the family because nursing staff teaches the family how to help provide these medications to their loved one. We as EMS providers can also assist with giving these medications to the patient. When patients are on hospice care and they have their comfort care kits at home, we also provide them with a bunch of documentation, and this form is one of them. It's a very much a generic form from the hospice entity that we advise them to hang this in a place to which first responders and other family members can see it. And what it is a list of things that if the family experiences any one of them, that they need to call hospice first before calling 911. These things include if for some reason the family thinks the patient needs to go to the hospital, or the patient thinks the patient's changed in their status or condition, or if the patient has pain or other symptoms that are not well controlled with the current medication regimen, or if the patient or caregiver has any questions, if they feel the patient needs any new procedures, tests, or treatments, or if the patient's died. They've been advised to always call hospice first. If a patient falls out of bed, which is very common in hospice patients because some of these hospice patients very much are still active, that would be one scenario to which we have trained them to call 911 first and then hospice second. And the reason why we do that is we want to make sure that this hospice patient gets off the floor in a timely manner and gets put back in bed or helped back to their feet so they're not in more pain. So this is a form that's provided to the family and the patient that I've tried to rearrange it so it's easier to flow. But what I want to highlight here is we do a good job in the nursing field around hospice on education. And with the medications that are common in these kits, which typically include morphine, Ativan, Haldol, and Dilaudid, we do a lot of education around the fact that these medications don't accelerate the death or dying process, but it provides the best comfort possible towards the end of life. And they're told, if your loved one's having shortness of breath or any pain, go ahead and give them some morphine. If they seem really anxious or if they're nauseated, go ahead and give them some Ativan. If they are agitated or they're dry heaving or still nauseous, there's Haldol. If they're in pain, you have Dilaudid or morphine as an opportunity for them. So these pictures are close-up views of the three most common medications that are used in those comfort care kits, being morphine, Haldol, and lorazepam, otherwise known as Ativan. Morphine is used for shortness of breath and pain. Haldol is used for agitation as well as nausea. And lorazepam is used for anxiety. As you can see, the concentration that they're in, as well as the formulary. These are all liquid PO medications. Nothing in the hospice world is IV. This is a photo of one of those medication bottles with the cap off. So again, this is designed for the lay person without any medical knowledge, and we in nursing will teach the family how to draw up medication. And it's very easy. Take the syringe at the bottom, pull off the cap. It's smooth. You stick it in the top of the medication bottle so it forms a seal. Flip the medication bottle up, draw up the medication dose that they need, put the medication bottle back down, pull the syringe out. Very simple, easy design. That's why anybody that responds in EMS, all license levels, can assist with this process because there's no sharps involved. So let's dive into our hospice care protocol. First and foremost, at the EMT level, which is a majority of the protocol, contact the hospice team. That is the number one thing at all license levels we should be doing. Next is contact a paramedic for medication administration if you don't feel comfortable doing so. And then the common things that we will see hospice patients for are breakthrough pain, anxiety, shortness of breath, constipation, terminal dehydration, confusion, delirium. The protocol does a good job of kind of walking us through how this stuff should be treated. Remember, breakthrough pain, they have medications in their comfort care kit for this. Same thing with anxiety. Same thing for shortness of breath. Oxygen is used in the hospice world, but a lot of patients prefer just to have a fan blow air around the room, circulate the air. Constipation. By default, with these patients taking morphine or Dilaudid on a regular basis for pain management, a side effect of those medications is constipation. So when we have patients that are taking the pain medication regimen, they're also taking a bowel regimen of medications to help them pass stools. But constipation is very common. Terminal dehydration. As they transition to the final phase of life, they're no longer eating or drinking, typically. So dehydration is expected. So what we do with our goal is to make sure that if they can tolerate it, ice chips, popsicles, or even chapstick, a lip moisturizer. We're not starting IVs and giving fluid resuscitation. Confusion, delirium, again, very common towards the end of life. What we treat for this, we speak slowly and calm to them, remind the patient where they are and who they are. And then we make sure that they have the stuff that they need, eyeglasses, hearing aids, and then limit the noise in the room. Again, we are not grabbing a blood sugar. We are not giving them D50. We're not giving them fluid. This is part of the death and dying process. Nausea and vomiting. At the advanced level, these patients have Haldol. A lot of them have Zofran in the home as well. So that's one thing that we could treat from their kits that are there at the advanced level. And then again, they have all the medications they need for their pain. We should not be giving narcotics to these patients, ketamine, fentanyl, unless we're transporting them. And we'll go into that in a future slide. As the hospice care protocol continues, there's a pearls section, which I think is wonderful. So some of the pearls. Breakthrough pain assessment and management is important in patients with advanced disease as they may have a high burden of pain, be opiate tolerant, and already receiving high dose of opiates. They have lots of anxiety. Some people have mild, some people have severe. They're nearing the death process. Sometimes that can be scary. Terminal secretions are noisy, gurgling respirations caused by secretions accumulating in the lungs of the oral pharynx. We don't suction them in hospice. We give them a medication that helps dry up the secretions. But besides that, we just reposition them into bed. If they have secretions that are bad enough, we turn them on their side, and then they will just naturally drain from the mouth, and we clean it up, with a towel and make them look presentable. But we don't go in and suction these patients. Terminal dyspnea is experienced in patients that are expected to die within hours to days. That's quite a range, I know. But again, with the shortness of breath, we treat that with our morphine. Constipation, again, frequently is a cause of nausea and vomiting because they get in so much pain, discomfort. Again, it's usually related to the opiates that we give them. And we do have medications to help start a bowel regimen to make that more regular. Nausea and vomiting is something we really try to stay on top of at the end of life. That's why they have Haldol, and some of the patients take Zofran for that as well. Fever, infection, that's also part of the dying process, and we don't treat that. If a patient has a fever of 102, we still make sure they're comfortable, reposition them. Maybe we get rid of the heavy blanket that's on top of them, put a fan in the room, but we're not doing IV antibiotics. We're not treating them with Tylenol. It's just part of the process. Sepsis, as you can imagine, with the end of life and end organ failure, multiple organs that are failing, if they have any sort of infection, it overwhelms them relatively quickly, and that's just part of the process that we don't reverse either. Delirium at the end of life is very, very common, and usually this is very scary to families. Usually it's caused by a combination of the medications, dehydration, infection, hypoxia. This might be a common reason for them to call us because their loved one is not acting normally. But again, we have something like lorazepam or Haldol that we can give to these patients, even morphine, to make them more comfortable. I wanted to share this because I thought it was very interesting. The observation is that during cardiac arrest and CPR, the brain waves are still normal for up to an hour, which is fairly remarkable. And this was in heart.org back in 2022. Why is this important? If you have a patient who is nearing the end of death or has died and you show up, still talk to them like they're there. It's a very odd thing to do. In nursing, it's an honor for us to do postmortem care, so the care that we provide to the patient after they've passed. During postmortem care, we literally talk to them like they're alive. We explain to them what we're doing. A lot of times we put music on in the room, their favorite music, and we make it a very positive experience for them because studies have shown that they can still hear us, or brain waves are still activating up to an hour. So let's talk about death with dignity. So back in 2019, Maine became one of the 11 states to have a death and dignity law. The other states include California, Colorado, District of Columbia, Hawaii, Montana, New Jersey, New Mexico, Oregon, Vermont, and Washington. This is an excellent thing for our patients. The Maine Death and Dignity Act went effective in September 2019. Again, Maine is one of 11 states. It does not matter your opinion of this law. What matters is that you must honor what the patient wants as a healthcare professional. Remember, not everybody wants to be saved. These patients that are eligible for the death of dignity law are terminally ill state residents who have less than 6 months to live, and they have to be able to legally obtain an oral prescription medication that they take voluntarily without assistance to peacefully end their life. In order to be eligible for that, got to be 18 years of age, got to be diagnosed with a terminal illness, and it has to be confirmed by 2 physicians. These patients have to be of sound mind, be able to make an informed decision, and they have to be able to ingest the medication without assistance. The foundation behind this choice is that the patient is competent and voluntarily agreeing that they are dying and that they want to end their own life. What's unique about this is two witnesses have to confirm that the patient's acting voluntarily, and they don't have to be family members. It could be two best friends. The two physicians must confirm that the patient meets the criteria. Usually one is their PCP, and the second is a specially trained doctor, typically an oncologist, who has went through specialty training for this law, who is an independent physician of this patient. What's important about this is that these patients can rescind this request at any time. All the patient's life insurance policies are protected. So unlike suicide, to which a lot of times null and voids patients' life insurances, death with dignity does not, because on the death certificate, their reason for death is whatever their terminal illness is. And the patient has the right at any time during this process just to stop. This is a form that the state requires them. It's the request for medication to end my life in a humane and dignified manner. This is a declaration of the patient. So basically what it is, the patient fills it out, they date it, they initial that they had two people sign it. The two signatures are on the second page. This goes to the state with a letter requesting this process to be allowed for them. They have to do this process twice in order to get the medication. So how does it work? So a patient gets approved for death with dignity. They get a formulary of medications that is comprised of between 2 and 5 medications. They will not disclose what they are, but we know that each one of them in their concentration are lethal themselves. The reason why they don't disclose what these medications are is they don't want patients or basement scientists to try to come up with this and then kind of do an aftermarket sort of thing. So they get these medications from the pharmacy. They have 1 month to utilize them. As I explained earlier, the patients have to self-administer these medications. So what does that mean? Exactly what I said. They have to be able to self-administer it. If the patient's on hospice, the hospice nurse, when it comes time for the patient to take these medications, will step out of the residence. And the only people allowed in the residence while this is occurring is a physician, so typically one of the oncologists who were the second physician who signed off on this. He or she will typically show up, or a licensed death doula is allowed to be there. So they draw up this medication. Excuse me. It's a liquid. It's about 2 mLs. So we know that's not a lot. And they consume it orally. Or if they have a peg tube, the patient themselves can administer it in their peg tube. Or if they have a rectal tube, they can self-administer it into that. Studies have shown by the time the patient consumes it PO, so they put the liquid in their mouth and they swallow it, before they put the cup down, they become unresponsive. It works that quick. And then a patient typically passes or dies within minutes, but it can last up to about 90 minutes. But they're heavily sedated, they're not in any pain. Once the patient consumes the medication, then the hospice nurse can return to the residence or where the patient is located and continue the hospice care. Side note, we as hospice nurses, we don't advocate for or against the death and dignity process. It is up to the patient, their family, and their personal physician to initiate, fill out the paperwork, and set this up. Hospice nursing is just there to treat the patient before and after this medication is consumed. So let's go into some statistics. So when the death and dignity law was being discussed at the state level, there was a huge panic and uproar against it because folks thought this was going to be another version of Dr. Kevorkian coming in and just killing a whole bunch of people. People are going to commit suicide doing this. It's going to be used time and time again, hundreds if not thousands of times every single year. This is just a bad thing. All false. So what I'm going to show here with this data is prescriptions is defined as the amount of people that went through the process, got approved for the medications, and are able to carry out the death and dignity themselves. And then the second column is the amount of people that successfully went through the entire process and utilized the medications that were prescribed to them. And I want you to look at the trend. 2019, so remember this came out in September 2019. One person got the prescription and he or she went through the process. So 100% of people in 2019. 2020, 50 prescriptions, only 30 people consumed it. 2021, 67, 46 people. 22, 54 prescriptions, 40 people. 23, 76 prescriptions, 53 people. 24, 66 people got the prescription, and 80 of them went through the process. 2025 has not been released yet. It usually gets released around June. So what do we see with this trend? A, it's not hundreds of people or even thousands that are taking this medication and ending their own life. That's number one. Number two, not everybody who got the prescription end up dying by using the prescription. Why is that? One of two reasons have occurred. One, they opted not to go through the process. Or two, their disease process advanced too quickly that they weren't able to self-administer it, so they couldn't utilize a prescription. If you short of 2019, if you look, you're looking at about a 50 to 60% usage rate of the prescription. Again, 40 or 50 people every year, not thousands like people thought. So let's pivot and go to some of the legal documentation. So what I want to do is go over a pulse versus a DNR. What is the difference? A pulse helps a patient keep control over his or her medical care at the end of their life, where the DNR tells a healthcare provider whether or not they want CPR to be initiated in the event of medical emergency, and they stop breathing and no longer have a pulse. So a pulse. What a pulse is, again, it allows a patient to outline how they want their treatment to progress should they need it. This is different from an advance directive. An advance directive is from the patient. Usually it's done by a lawyer, and it may not even be medical in nature, where a pulse is a medical order signed by a physician. Some of the things included in the pulse is whether or not they want CPR, whether they want full treatment, so you're talking CPR, ventilators, IV medications, whether or not they want prolonged heroic life efforts at the hospitals, so you're talking artificial airways, meaning a trach, a peg tube, whether or not they want organ donation, so it kind of outlines everything that they want leading up to their death. A DNR is the patient has signed the form that they do not want to be resuscitated if they are no longer breathing and no longer have a pulse. That is important because a DNR does not mean do not treat. It means do not resuscitate. So let me throw this scenario at you. You have a patient who has a known DNR. He or she may be a regular patient. You go there for an overdose. You show up there in respiratory arrest, but they still have a pulse. Do you treat them? The answer, absolutely. You treat it as an overdose patient. You ventilate them with end-tidal CO2. Try to reverse it with Narcan if you can, if the medication is reversible in Narcan, and you take them to the hospital. So the protocol does a good job outlining a few things about expiration around the DNR. First and foremost, the DNR needs to be signed by a doctor as well as a patient. That's number one. Number two, it remains in effect until the expiration date if there's one on the form, or if there's no expiration date on the form, until the patient cancels it. We used to have an issue a number of years ago to which patients were required to date and sign a DNR every year. So think of this scenario. A patient's DNR expires on December 31st, and then we respond to them on January 4th for them being in cardiac arrest, and the family hands you a DNR that expired 5 days prior. We know what their wishes were. They just didn't have time to get back to the doctor in order to have another one re-signed. So it really put us in a tough spot a lot of the times. So Maine EMS has lifted that requirement of it being dated, but just know that the patient has the right to revoke it. Not the family, but the patient has the right to revoke it if there's no expiration date on it. When it comes to the documentation itself, in the new technology age that we're in, many people don't walk around with their DNR in their pocket or a vial of life anymore, to be perfectly honest. So a photocopy is acceptable as long as it appears to be valid, it's legible, and you can understand what it says. Also remember, DNR forms vary from state to state. So if you have a patient in cardiac arrest and a loved one walks up from New Mexico with a tablet or a phone and goes, no, don't work my loved one because they have a DNR, I would initiate BLS CPR while I try to interpret the DNR. If it looks legit and it's legible, you can honor it. If you have any questions at all, call on medical control, but they can tell you the same thing. What I will tell you is, if you're going to honor that DNR, please make sure that before you leave, you get a copy of that. So have that patient's family member text that to you, email it to you, make sure you have it and attach it to your PCR, because that is a documentation for your CYA. So that way there, the family can't go on the news at 8 o'clock and say, hey, I'm visiting Maine and my loved one died and the paramedics didn't do anything, where you actually have that form for verification that it was a legit DNR. So again, please get a copy of it if it's an electronic format and attach it to your PCR. So where a DNR is filled out by the patient for do not resuscitate, if a patient has a terminal illness to which they can't sign, for example, ALS or severe Alzheimer's dementia, their power of medical can sign and fill out a Maine EMS comfort care do not resuscitate on behalf of the patient, and that is used in the same way as a DNR. Initiation of orchestration. So, like I mentioned at the beginning of the presentation, if you took this presentation live, I have a variety of very good videos about this process. I highly recommend you taking one of my in-person classes around this. But there's a video at the very beginning that discusses the initiation of orchestration and how a family member lost a child and they went through this process as the mother and not the healthcare provider. And what the initiation orchestration is, initiation orchestration invites the family to watch what we're doing. About 10 or 12 years ago, so we're talking early 2000s, this was a big thing in the ER and it worked its way out in the field. It used to be, it's going to be too traumatic for the family. You don't want them to see what we're doing. And we realize through trial and error and studies that it's actually therapeutic for some folks to actually watch us resuscitate their loved ones so they can see that we're doing everything we can to save them. Now, again, the caveat is we need to make sure that the family members are safe and they have the mental capacity to see this. Usually in our world, if we have a patient in cardiac arrest, law enforcement is there should we need them. But this is the fact to which we invite a family member to come in and watch. Best practices, if you're going to do this, is have a member from your department be with that family member, and that's their dedicated role. So that way they can explain to the family what's going on. Remember, in EMS, rank doesn't matter. Just because your lieutenant's there or the fire chief or the deputy fire chief doesn't mean that they get that role, because some of those folks don't want to be part of that role, or probably not the best people to do that. So it's okay to have someone who is not an officer be the person assigned to that. Saturate their senses. We know there's 5 different senses. The big thing is, as these families watch us resuscitate their loved one, they need to hear what's going on, but we need to be respectful, meaning we should always limit our conversation to, good job on your CPR compressions. Hey, can you please make sure you ventilate that patient a little bit slower? Please go ahead and start that IV on that left side for me. Can you please give me medication X, and so forth. This is not the time for us to be discussing anything else other than patient care. Empower the family to be able to make their own decisions. What this means is, if the family is capable, empower them to watch, as we discussed earlier, but make the decisions after the fact. So we know if we work in arrest in the field, short of being a hospice patient, it's a crime scene until proven otherwise. So once it is deemed not to be a crime scene, this is when the family is empowered to be able to clean them up, put them in a different outfit, comb their hair, just take care of them in the way that whether their religion or culture requires, or what they need to do to help the healing process for themselves. Prepare. Prepare yourself for this sort of traumatic event as EMS providers. That's what you're doing today by taking this class. Really good YouTube videos out there on death and dying. Our colleagues in the hospice nursing world, this is their specialty, so a lot of the stuff that this presentation is based upon is all around the nursing world, because again, much more controlled setting, way more data and studies around it, and nursing's been around a long time. So please continue to take programs like this one to make you more comfortable with the death and dying process. Heal. This is one that we tend to forget. We need to start the healing process for ourselves. Have someone you can talk to after having a bad call. What do you have for stress relievers? Provider burnout and first responder suicides are a real thing, and it can't be ignored anymore. We as a profession average more than 100 suicides a year between police, fire, EMS, and dispatch. That on average is a suicide once every 3 days. We need to start focusing on self-care and taking care of ourselves as well, or we can't help anybody else. I like to share this acronym called grieving. So this is a way for us to kind of have a trail map on the process to tell a loved one's family member that they've died. So first and foremost, gather everyone, whether it's another EMT or paramedic or a police officer that's with you, have him or her come and get anybody who wants to hear the message all together at once. Part of this gathering, we need to make sure we do it in a private setting. In a busy city, on the sidewalk is not a good place to let somebody know that their loved one has died. Try to find some place that's private, even if you have to bring them into the back of your ambulance if the patient's in their home. Give them some privacy. Do you have any resources that can help? A chaplain's a good one. Some departments have an on-call chaplain. Maybe a chaplain should be there to help with this. When you go to notify the family that their loved one has died, you need to identify yourself. Slow, get at their level, be very clear. Hi, my name is Brad. I'm the paramedic taking care of your dad, Joe. Please know the name of your patient. The last thing you want to do is use the wrong name or not know the patient's name. You need to make this a humanizing experience, and this is where the empathy starts. If you haven't done so already, at this point, you educate or explain the treatments that you provided. So after you introduce yourself, you're sitting beside the family members, you're below them eye level wise. Hi, my name is Brad. I'm the paramedic that took care of your dad, Joe. For the last 45 minutes, we performed high-performance CPR. I put a breathing tube down his throat and to help him breathe. We gave medications to try to restart the heart. We defibrillated to try to get their heart into a normal rhythm, whatever you did, but it didn't work. Your husband has died. So you need to verify the death. Remember, everybody dies. They didn't pass on to a better spot. They didn't meet the maker. They didn't take a one-way ticket to heaven. You need to be very clear. They died. And then pause. Now we know patients, family members are going to respond in a variety of different ways. Remember, scene safety is always number one priority. But allow them to grieve. Some people will be angry. Some people will be sad. Some people are going to bargain. Some people aren't going to believe you. There are some folks you may have to say that they have died multiple times, because after you told them the first time, they might say, okay, can I go talk to them right now? I'm so sorry, ma'am. Your dad has died. Oh, no, I get that. But, like, will I be able to take him home? No, ma'am. Your husband has died. And now we need to figure out what the next step is. You need to be very black and white with them. Inquire about any questions. They might have a whole bunch of questions for you. What happened? Did you put those paddles on his chest and try to shock him like on TV? Did you do everything you can? Did he feel it? Oh boy, that's a loaded question. Did he feel it? We don't know if the loved one who had just passed felt it. So the best way to answer that is, sir or ma'am, I don't know if he felt it, but what I can tell you is, when I arrived, he wasn't breathing and he didn't have a pulse. Do not go down the rabbit hole of saying he didn't feel a thing, because typically the next question will be, how do you know? Don't go there. Just simply say, when I got to him, ma'am, and we started to care for him, he didn't have a pulse and he wasn't breathing. The nuts and bolts. So what's the next steps? So a lot of times the family's going to ask, now what do I do? We as EMS professionals, is there somebody we can call for you if somebody's not there already? What's going to happen next is we explain to them that the police department is going to help you and your family get the patient to where they need to go to next, the funeral home or whatever arrangements that the family wants. But kind of explain to them that, hey, the police department is going to take over after that, and but we're here for you. And then finally, give your contact information, not your personal contact information, but the department's contact information. I like to end these scenarios or these contacts with, I'm so sorry for your loss. If you need anything from XYZ Fire Department, please call the station at any time. We're here for you, and give them your station phone number. Organ donation. So Maine EMS requires, as of 2023, for us to contact the New England Donor Services every time we have a death in the field. The reason for this is the number one organ that's needed or harvested is skin. So some of these patients, in theory, would be organ donation candidates. So something for you to consider. If you make this recommendation, you're not involving the family. You're simply calling the number, the 1-800-446-6362. You'll get someone on the other end of the line. It'll be a person, and they'll ask you the patient's name, date of birth, what happened, if you know of any medical history, any allergies, and some other medical questions. And then they'll ask for a contact number for the family, and that's where you end it. And then it's up to them to kind of sift through whether or not they're going to call or not. You document in your PCR, New England Donor Services were contacted at this time, and that's it. There are some absolute rule outs to which we can make in the field, and if we don't, they will do it through the New England Donor Services. There's 4 absolute rule outs, meaning they are not eligible for organ donation. If there's obvious signs of body breakdown or decomposition, if the patient was last known to be alive greater than 18 hours ago, if there's any evidence of IV drug abuse, or if there's known HIV or hepatitis. If you think you have a patient who would be a good organ donor in the field, you can absolutely transport them to their appropriate facility, being Maine Medical Center or Eastern Maine Medical Center, for the sole purpose of organ donation. Now, if you're going to do that, you need to treat your patient to the fullest extent, meaning if they're in asystolic arrest, and let's say it's a GSW to the head, and they don't appear to be IV drug abuse user, you don't know if they have any hepatitis or HIV, but you think this is a young, healthy person, I think they'd be an organ donor. They need to be intubated. They need to have the Lucas going continuously or high performance CPR manually. You're talking IV medication, so every 3 to 5 minutes, you treat them like you would anybody else all the way to the hospital. The difference being, when you call the radio report in, I would do it over the phone. And the reason why I do it over the phone is the first thing I would tell the person on the phone is, hey, I have an asystolic arrest, which I think would be a great organ donor. We are intubated, we've done the ACLS protocols, the whole 9 yards. That way they can then start to scramble the OR and the team who starts this process of determining whether or not they're a candidate. But you need to be very clear, because if you roll in with an asystolic arrest of 25 minutes and don't let anybody know you're doing this for organ donation purposes, the doctor's going to look at you pretty strangely, because they know that we call these sort of calls in the field. So just give the hospital a heads up over a cell phone. So let's talk about organ donation. So on people's driver's licenses, like this example here that's taken from the state of Maine website, obviously not a real person, on the lower right-hand corner of that license, it has a picture of him with a little donor heart. What people don't realize is that donor heart is something that the patient has acknowledged that they want to be considered for organ donation, but there is no tracking form at the state. So it's not like a doctor can go into a system on the state of Maine website and type in organ donors and have a complete list of everybody that checked this box when they get their driver's license. It doesn't exist. What this organ donor box does is it tells NEDS that you want to be considered, but it does not guarantee you'll be an organ donor. We need to heal too. So this is where we start to discuss self-care. So there is a phenomenon out there called the general adaptation syndrome. And what it is, and this diagram does a very good job of explaining it, it's how we respond to alarms or medical calls. So the alarm goes off. There's the stressor. Our body produces adrenaline, and then we go into fight or flight. Then we start to build resistance. We start to learn how to cope with these stressors. We start to adapt to the environment, and then our body starts to get a toll taken on them, and then we become exhausted. Round and round we go. We do this time and time again. So we have a call at 8 o'clock. It's a cardiac arrest. We clear the cardiac arrest at 9:15. We're driving back to the station. Tone goes off again for a little old lady who fell out of bed. We go from that cardiac arrest call to a public assist. From there, we go to an accident. From there, we go to a structure fire and so forth. Alarms go off. We start to build that resistance, and then we become exhausted. It's a vicious cycle for us. Part of our stress reaction, as outlined by the IFF, this is from their peer resource group. It's an excellent resource if you need stress debriefing after a call. How to understand reactions to potentially traumatic events, so PTEs. They divide it into 4 different columns: physical, cognitive, emotional, and behavioral. So what happens when we have a stress reaction? We become fatigued. Some people become nauseous, dizzy, headaches. Blood pressure starts to go through the roof. Increased heart rate, chest pain, and we don't become hungry. Cognitively, we can become confused, have nightmares, poor problem solving, poor attention to details. Emotionally, we become fearful, guilty, grief-stricken. We start to have panic attacks. We start to experience shame, anxiety, feeling overwhelmed. Our personality changes. We have intense anger outbursts. Behavioral. Some folks' response to stress is they start to withdraw. They become restless. Change in social activity. Maybe they went to the gym 5 days a week in CrossFit, and now they don't go to the gym anymore, and all they do is drink. Increase of nicotine, or they start smoking. These are all flags for us to look out for each other that some people can have as a response when they have a stress reaction. Not all wounds are visible. There's something out there called compassion fatigue, or other people like to call it burnout. It's when we become emotionally exhausted. Healthcare workers go to the same calls, the same types of calls, same area, do the same thing over and over and over again, and eventually some people just get burned out. We need to correct that. Another thing that's very dangerous for us is something called second victim syndrome. It's when a medical error occurs that inflicts significant harm on the patient and the patient's family. Keyword being medical error. A lot of us, as we go through this 20, 30, 40 years down the road, this stuff adds up. When it comes to the suicide rate in public safety, again, one of us take our own life every 3 days. Sometimes it's because of compassion fatigue or burnout, or they feel guilty that maybe they should have done something else differently, or they made an error that they felt caused the patient to lose his life. This is why, because of our constant stress reactions and the potential for burnout, we need to focus on ourselves. And it's something called self-care. What self-care is something outside of EMS that gives us purpose. Many of us who work in public safety have other jobs. Most of us have other jobs in the fire service. We go from our full-time job doing this line of work to a part-time job doing this line of work to a per diem job doing this line of work, and again, it all adds up. Self-care focuses on something completely different, where we have the opportunity to do our job and do it well, but have a place or an activity or a person that we can decompress and try to normalize ourselves. Some of those opportunities involve volunteering in your community, joining a gym like CrossFit, learning how to eat healthy. Massages are wonderful. Dog walking, if you have an animal. Officiating. I happen to do this. I'm also a high school basketball official. Something completely different from my medical field training, but it's wonderful. I get a chance to be around kids, sometimes nagging adults and parents in the stands, but that's okay. But it's just something very different to me. I did a whole lot of sports growing up, and this is a way for me to give back to my community, and again, be surrounded by young, youthful, next generation kids playing sports. Yoga, singing. I can't sing a tune. This one's not for me. But there are some people out there that can sing. Write a book, write a paper, write a letter. Read a book. We have books on tape. Just find something to do outside of EMS. Being in this field for over 20 years, I will tell you, this profession will change your perspective on life forever. I've made it my mission to always try to make one person smile every day. That was from the late Stephen McDonald, who was my paramedic preceptor, who died at the age of 51. If you are struggling, know that there are resources out there and available to us to help us survive this profession. And remember, it only takes about 120 seconds or 2 minutes to make a lasting impact in someone's life. Down at the bottom is my phone number. It's on 24/7. If you need someone to talk to, please, please, please reach out to me. Or I can steer you towards resources to which can help you. Thank you for spending the last hour with me over this really important topic. Special thank you to all these entities, but especially to Andwell Hospice of Southern Maine, Maine EMS, in the International Association for Firefighters. Thank you very much. I hope you enjoy the presentation.